Our population is aging rapidly, and people are living longer and better than ever before. How is the medical field preparing to treat their aging patients? Watch this episode of Aging Insights to find out. Hello, I'm Dr. Kathy Rowe, Executive Director of New Jersey Advocates for Aging Well. Today, I'd like to welcome our guest, Dr. David Barile, Medical Director and founders of the Goals of Care Coalition of New Jersey, and Dr. Catherine DeMarco from Hackensack University Medical Center. We're going to talk today about aging with patients and adaptations the medical field is making to meet their needs. So welcome and thank you for joining us.
Thank you.
Thank you.
So my first question is, can you define for us the role of a geriatrician and how they compare to or differ from an internist or a family practitioner?
Sure, I'll take that one. I trained, after leaving medical school, I trained in internal medicine for 3 years. And like most geriatricians, I went on to do a geriatric fellowship. That was a 2-year fellowship at Mount Sinai. So geriatricians have additional training, usually additional training beyond either family medicine or internal medicine in the field of geriatrics, which is essentially care for the older adult. And these fellowships are typically 1 or 2 years of additional training. A geriatric doctor will have expertise in identifying things like dementia and delirium, but also have expertise and experience in looking at the patient as a body whole, right? And looking at what I call the interrelatedness of all the organs and problems. So we have expertise in managing a lot of overlapping problems like diabetes and hypertension and kidney failure, and bringing it all together.
Thank you. It's interesting because that's exactly why I thought of this topic. As a lifelong diabetic, I was talking to my endocrinologist about how to handle type 1 diabetes in a 75-year-old, 80-year-old. That was not what he was trained for in medical school. And at what point does a geriatrician learn how to manage an insulin pump? So this cross-training that you're talking about is really important as people live longer and live with more complex medical conditions.
Right. Yeah, and a lot of people ask me, when do I need a geriatrician, or who needs a geriatrician? And there's no perfect answer for that. I think the American Geriatric Society suggests that any adult with 3 or more chronic medical problems should probably see a geriatrician, or any adult over the age of 85 or so. But I don't like using age cutoffs because we all know that there are plenty of 65-year-olds out there with multiple medical problems that could use a geriatrician. And there are plenty of 80 or even 90-year-olds with no medical problems, entirely healthy, that would not require a geriatrician. So it depends, basically.
Absolutely. Thank you.
Mm-hmm. To add to that a bit, I think one of the beautiful things about having that geriatrician perspective is that there's an opportunity for the geriatrician and the family practitioner or internal medicine physician to receive consult by the geriatrician, and there could even be a transition of care as illness or age progresses. So I think that is a bridging relationship within our medical system that is developing further as our society in New Jersey ages in.
So as our demographics shift and we see people with increased quality and quantity of life, how is the medical field preparing for this?
Well, there's good news and bad news here. Would you like the bad news first?
Sure, give us the bad news first.
Generally, I think within the medical establishment, at least educational establishment, where we're training our young doctors in medical school and in residency training programs, there really is not enough good geriatric education, I think, being taught and instructed. So I think that, and sadly, not a lot of people are going into geriatric medicine. So doctors are graduating medical school and finishing their residency training, and instead of going into primary care, being a general practitioner, or going into geriatrics, they're choosing subspecialties. So, and there's a financial reason for this. There's a financial disincentive to go into geriatric medicine because a lot of people are borrowing a lot of money to go through medical school, and they need to pay it back. And they could more easily pay it back making $500,000 a year as a cardiologist or radiologist versus $200,000 a year as a geriatrician. So there's a financial disincentive. And the geriatric fellowships programs that are out there in the previous few years have not been filling. So they're empty. So they, a university setting might have 3 spots or 4 spots to train a geriatrician, and only 1 or 2 will be there filling those spots. So there's a huge shortage, I think. As the population gets older, we're having more and more older adults, we've got less and less geriatricians. I think there's, if presently there are about 7,000, I think, across the US, and we're projected to need about 30,000 or so over the next few years. If one geriatrician can care for 700 people, right? That's the number of geriatricians we'll need, but we don't have enough. People just aren't choosing this field. So that's the bad news. But I think that the good news here, and maybe Katie, you can expand on this, I think the role of the nurse practitioner moving forward will be key in solving some of this shortage of practitioners, because, and there's some evidence to suggest that older adults seen out in the community by nurse practitioners may fare better than seen by physicians. So there's a lot of positive things happening. I think that's one of them. That's one of the potential solutions. There are aging-friendly healthcare systems popping up. The John Hartford Foundation is funding this through the healthcare improvement initiatives. Hospitals are becoming age-friendly. And that means there are interventions that keep that elder safe from the hazards of hospitalization. When an older adult is admitted to the hospital, a lot of bad things can happen, right? Because they're frail and they're susceptible to more illnesses as they lie there in the hospital bed. So, and my hospital here in Princeton actually hopefully will become one of these hospitals that is age-friendly. And what that means is that we pay attention to things like goals of care, what matters to the patient. We pay attention to medications given. We pay attention to mentation and mobility, and keeping that patient healthy and well as they traverse the healthcare system. So there are some positive things on the horizon, but I think the big worry that we all have in this business, that where there just are not enough geriatric providers to go around. There will be a huge, there already is a shortage, and there will be a worsened shortage in the future.
And so in response to this, to this clinical gap, the nurse practitioners and the nursing field have really further developed the adult geriatric specialty within the master's or even doctorate concept. Currently, with adult geriatric nurse practitioner studies, there are enhanced geriatric and elder clinical hours within their practice compared to when we were, say, about 10 years ago, only adult focused. So I do agree with you that that the nurse practitioners can be a bridge to this particular, say, clinician to community ratio discordance. And I think that there's a wonderful relationship that is developed with all clinicians, but particularly within nursing, we're finding, and patients' voices are that they're very trusting of nurses and nurses practitioners. And then, of course, nurse practitioners have the benefit of working with the physicians and specialty geriatricians to even hone in on that interprofessional connection. through telehealth or other particular relationship and guidance. So I think there's a great opportunity about what the nursing field is developing because there is such great community need.
That's really good to hear. I know that other fields like family practice, internists have struggled to build a focus on primary care, but it sounds like nurse practitioners and the nursing field can help fill this gap of geriatricians.
Yeah, it's particularly important in New Jersey, I think, where we have not only a shortage of geriatricians, but a shortage of primary care doctors.
Right.
And one of the challenges I think that older adults have with multiple medical problems, they're visiting subspecialists, from one subspecialist to the next subspecialist.
Correct.
So they'll visit the heart doctor and then the lung doctor and then the kidney doctor. And there's no one physician or practitioner to bring together all this information and assimilate it and help the patient make sense of it. And that's one of the challenges I think we have here in New Jersey in particular. And that's something that's the primary responsibility, I think, one of the primary responsibilities in geriatric medicine is to collate all of that information and be the single source of information for the patient and help with that kind of decision making and coordination of care.
I find that geriatricians in particular, whether it is a physician-based geriatrician or an adult geriatric nurse practitioner, they are able to streamline the conversation with patients about those multiple illnesses or lifestyle changes from their illness. And it really allows patients to become, and their family members to become more actionable in their own care. Instead of identifying, which organ or which part is having a challenge, geriatricians are able to look at the whole picture and really give them that global view of how are you doing, how is your body doing, and how are you feeling. So that holistic comprehensiveness is truly a strength within this medical field.
So as you've brought up, there are more issues that come with age. And some of those could be hearing loss, vision change. How do we prepare doctors in those fields for dealing with older patients? Is there anything that's being done? Are they being prepared? Or what can we do to help them prepare for seeing older patients within their specialty?
Right. This is one of the challenges we have moving forward, and I think is the biggest problem. And I think what the government's trying to do, and so what states are trying to do, is to get more people to go into geriatric medicine. Well, that's going to be hard to do because of the salary and so on, and the way it's just sort of taught in medical school. What I think should be done, and we're seeing small programs pop up. I think that we should embed geriatric medicine and geriatric education within these subspecialties. So if you want to be a cardiologist, right, you can go to your cardiologist fellowship and you learn about cardiology, but with a special emphasis on aging and cardiology, right? And how the aging or older adults may adapt to illness. So we should train, I think, better those subspecialists in geriatric care. There are a couple of programs in New York that are doing that, some out in LA, but I think we need more of that. I think we need to better educate young doctors in training on some basic geriatric principles, regardless of what discipline they're going into.
And Katie, what about the nursing field with training?
From a nursing field, we are enhancing training, although we're not necessarily in the specialty of working with eyes, working with those classic audiology or hearing and ear concepts. I think that from a nursing perspective, we often look at organizations and programs as live beings. And with that in mind, nurses and nurse practitioners are often integrated, not as the specialists, but often integrated into these clinics. And what I see that their strength is navigation through the healthcare system, advocacy of hearing the need and coordinating that care along with the subspecialist. But what we're also seeing within our state and nationally is that networks, healthcare networks, are being formulated to help streamline primary care to specialty, and also the reverse, specialty care physicians and practices that frankly need more help with primary care needs. So there is a pendulum of communication and back and forth. As we develop our healthcare networks in New Jersey, I see that pathway of communication being enhanced. I think that's extremely important. Just last week, for example, I had someone that was sharing their story about, they had a left hand, quote unquote, problem. Well, that left hand specialist did a great job sending the patient to a geriatric neurologist, and it happened to be ALS that was diagnosed. So our specialists are really leaning in on our primary care physicians for their specialty. I think it's becoming more honored from what I'm observing over the last few years.
That's great to hear. That sounds like progress. So one problem that I've heard from several people is that their physician retires, and a lot of internists, family practitioners, somebody does not want to take on a 75-year-old patient or a patient on Medicare or with comorbidities. What do you say to that person that after retirement, they are looking for a new practitioner? Where do they start to look, and how do they find one?
Sure. I think in particular, this past COVID pandemic experience, there have been clinicians that are retiring and maybe differently than they would have if we didn't have this pandemic. And one of the recommendations that I would suggest is working with a care case manager to identify, what kind of local or telehealth resources are available. I'm under the proponent that if someone has the ability to call and even interview their clinician to see if it's a match, I would recommend highly to do that. This is a clinical relationship that is of importance. And I think a nurse case manager through insurance or other resources could be extremely helpful and ultimately personalize that next step of care.
Yeah, I would agree with that. The importance of geriatric case managers moving forward will be really, really, I think, super important. And the one option also, if your physician is retiring, is to call a local senior center or call a local academic center or your hospital and find out which geriatricians are available and who's available to take on new patients or primary care doctors. But it's a challenge because they're just, like I mentioned, and we mentioned already, there's a shortage. Of the 7,000 or so geriatricians nationally, I think only half are working full time, and they're retiring faster than they're graduating geriatric doctors, right? So the shortage is just going to get worse. But contacting a local hospital or local senior center, or getting involved in case managers, geriatric case managers, I think would be an important step.
And the geriatric case manager, if they have a Medicare Advantage plan, they can call that plan or their insurer to find a geriatric case manager?
Absolutely.
Thank you. So many people with chronic conditions are living longer and better thanks to improved medical care. At what point do they see their specialist, and at what point will a geriatrician take care of their needs?
a geriatric doctor can be the primary care doctor and oversee and coordinate all of the care. Some patients or some primary care doctors use the geriatrician in a consultant role. So for example, once a year or twice a year, that frail elder may go visit the geriatrician just to have a checkup and a look from a geriatrician's perspective regarding appropriateness of medications, for example, or screening for balance issues or cognitive issues and so on, advanced care planning issues, home setting and so on. So there's a role, I think, for the geriatrician to be the primary care doctor, but also a role for the geriatric doctor to be the consultant and to just offer an opinion about medications and so on, and give that opinion back to the primary care doctor.
So as patients age and as they are seeing more specialists and have a broader network of physicians and caregivers helping them, what do we need to keep in mind to help make decisions based on their prognosis, how to make their care personal?
Right. Yeah, and this is actually what really drew me to geriatrics, I think, what I find particularly interesting in geriatric medicine, and that is everyone ages differently. And we all know people that may be in the same age group, but very, very different health statuses. So I can see an 80-year-old in my office who is entirely healthy and well and expected to live another 10 or so years or beyond. And then the next patient, who's also 80, may come in a wheelchair with a lot of frailty and perhaps dementia and a lot of medical issues. And that person's future is very different from the previous patient. And I think that it's really important for clinicians and for patients and decision makers to ask about the prognosis and talk about the future and make some medical decisions in the context of their prognosis or future. So for example, if we expect the person to be with us for another decade or so, then it may be important to get that mammogram. It may be important to do more healthcare screenings and health maintenance and so on. Whereas if someone might be entering into the final year or two of life, what may be more important is to talk about advanced care planning and what's important during this time remaining. And then align personal goals of care with available therapies so that we're not burdening that person with unnecessary treatment interventions or healthcare costs too, right? Because it's quite expensive and often it's unwanted care. Katie, do you want to expand on that?
Yeah, when we start personalizing our communication about how our health or illness is affecting our day-to-day lifestyle, the context that Dr. Barile was talking about is extremely important to have care preferences focused on. People absolutely think about the now, and people also think about their future differently, as far as future may be next week for some, where future may be 3 years from now. So I think it's extremely important to be continuous open communication within that clinician and family-centered conversation, because oftentimes elders, although we anticipate that they're going to be independent, it also is likely that they are family-centered and getting different caregivers to help them in different joys or even bathing themselves, driving themselves to the appointment. So I think it's extremely important to start that quality of life-centered discussion. And when we, the clinicians, start that conversation, it really invites and opens up the opportunity for the family and the person who's ill, the elder, to continue that conversation casually at dinner, at different times where things could be easier or more difficult. This is not a one-time discussion, advanced care planning or care preference discussions. this is an evolutionary transitional conversation that can bring you to different points of your life. And for us, we want to be able to honor and respect what is important to you.
Katie, thank you for bringing that up, the importance of the conversation. I know some of the best medical advice I ever got was to have the conversation at home with my family, because what you decide beforehand is very different than what you would decide or feel in the heat of the moment in a medical crisis. And it's important to encourage people to have the conversations when they can with the people that would be there with them. I'd like to thank our guests for joining us today, Dr. Catherine DeMarco and Dr. David Barile. You've really given us some important things to think about, and thank you for your time.
Thank you for having
Thank
me.
you.
This is Dr. Kathy Rowe from New Jersey Advocates for Aging Well. Thank you for joining us for this episode of Aging Insights, brought to you by our supporters and viewers like you. To watch this and other episodes of Aging Insights, you can go to our website, www.njaaw.org. We have over 100 episodes on a wide range of topics to support and help residents age well in New Jersey. I look forward to seeing you next time. Be safe and be well.